I think the first step is to really develop a collaborative approach to dealing with patients and work with the people doing the diagnoses and doing the biopsies, the pulmonologists, the thoracic surgeons, the interventional radiologists, and educate them on the importance of getting adequate biopsies for molecular testing. Years ago, we prided ourselves in getting a diagnosis on the basis of a skinny needle biopsy with just a few cells, and that was all you needed to know. But now it's essential for us to get adequate tissue for molecular testing. And at my institution, the people doing the biopsies understand this importance and actually send the biomarker testing as soon as the diagnosis is made, so that I often will have the molecular profile of the tumors when, I see the patient for the first time as a medical oncologist. A mistake is to wait a couple of weeks after the diagnosis is made for the appointment for the medical oncologist, and then have the medical oncologist order the test. And often what we find out is that the biopsy was inadequate and needs to be repeated. And those are all steps that impede the rapid understanding of optimal therapy for our patients. So, and then we need to work with the institutions and pathology departments to expedite the results reporting for these panels or shipping of samples outside. We do in-house testing at my institution, but also notification of physicians of the results when they come out. Sometimes they're just sent in an email that doesn't get noticed. So we need to do a better job of getting EMR notifications and recording of these molecular testing results, so that they're listed with the priority that they should have and acted upon rapidly. The newest and practice-changing approaches for biomarkers really impact the earlier stage disease, and in fact, resectable lung cancer, where historically we could improve outcomes by 3 to 5% giving chemotherapy in the post-surgical setting. But now with biomarker testing, we can do, we have multiple approvals for targeted therapies in the adjuvant setting after surgery, with dramatic improvements in progression-free survival. For just very recently, a couple of months ago, approved was adjuvant alectinib in ALK fusion positive patients, improving disease-free survival dramatically, with hazard ratios of in the 0.2 range, and also improving brain progression-free survival, and is just a pill-a-day kind of therapy that can dramatically improve the outcome prospects for these patients, half of whom are destined to recur otherwise. So this really helps improve that. I think there's, in general, an increasing awareness of the importance of educating both the public and practicing physicians on these latest developments in lung cancer. For a long time, the societies and advocacy groups really were quite silent or didn't exist in support of lung cancer. But now it's becoming recognized that really a focus needs to be on optimal management of lung cancer, and which is still the #1 cause of cancer death in both men and women, which is not widely recognized. And now we have screening, lung cancer screening, that's highly effective in reducing mortality. We have the these biomarkers, and we have to make sure that we don't just discover better ways to treat lung cancer. We have to implement it in practice and incorporate that into standard care in order for this knowledge to be optimally effective. And these kinds of initiatives really support that implementation science.